All right, guys, today we're going to talk about thoracic outlet syndrome. Okay, this is a coined term in 1956, and it essentially applies to, best characterization of the neurovascular compromise of the upper extremity due to pressure on the nerves and vessels at the thoracic outlet. So some quick epidemiology here. It affects 1.5% of Americans. Basically emerges in the 20 to 50-year-old range. Affects females with a predominance of 3 to 1, no racial predominance. Okay, there's 3 sites of compression. We'll talk about these. So regardless of the patient's symptoms, there are 3 basic areas that the insult could occur. One is the costoclavicular triangle, second is interscalene, and third is the pectoralis minor space. And of course, we're going to talk about each of these in detail here. Okay, so first the costoclavicular triangle. Okay, so this is bordered anteriorly, and each of these we're going to talk about essentially what it's called, how it's bordered, what's in it. Okay, so just kind of stick with the repetitive pattern here. So the costoclavicular triangle is bordered anteriorly by the clavicle and the subclavian, posterior medially by the first rib, and posterior laterally by the scapula. And so the superior border of the scapula, to be particular. Okay, so I'll show you a picture here after we talk about what it contains. Okay, so it contains the subclavian vein only. Now I ordered these based upon the fact that the first of these, the costoclavicular triangle, only contains the subclavian vein. Okay, so that occurs right here. Can you find it? I'll give you a big arrow. Here we go, right here under the clavicle. So it's essentially compression underneath the clavicle. Makes a lot of sense. Another image here showing that, well, the nerve could definitely be impinged there underneath the clavicle. All right, so regardless of the symptoms, again, there's these 3 areas. The first that we talked about, the costoclavicular triangle, the second, the interscalene, and the third, the pectoralis minor. So we're going to talk about the interscalene now, so between scalenes. So this is inferiorly bordered by the first rib, okay, but anteriorly by the anterior scalene and posterior by the posterior scalene, all right? So the interscalene triangle, now the first one, if you remember, contains only the subclavian vein. This one's going to contain the subclavian vein and the brachial plexus, okay? And this, if you can think about where this would be, there's this at the top of the screen of the 2 scalenes. Here is the interscalene triangle here, okay? So it contains the brachial plexus there up top, of course, and the scalene, and the subclavian vein. It's between the posterior, the pectoralis muscle and the chest wall, okay? So it contains, just like the other one did, as again we're building up. So the first was subclavian vein, then it's a subclavian vein and brachial plexus, and this is subclavian vein, subclavian artery, and the brachial plexus. Okay, and that's located right here. You can kind of see on the second image that this essentially goes through there, and so between the first rib and the chest, I guess, which composes the beginning of the chest wall, and then the chest wall itself, underneath that pectoralis minor muscle, there's a compression there, and that compression, that acute angle compression, is what causes the neurovascular compromise. All right, so there's the defects can be numerous. So sometimes it's the muscle getting too big, sometimes it's the bone getting too big, sometimes it's something else. Let's go through those. So bony defects start, and probably most significantly, are attributed to the cervical ribs. This is a supernumerary cervical rib called neck ribs. Okay. Here's an image of what the neck ribs are. Essentially, it's just another rib that comes off above the T1. So this would be, this is cervical rib. Here's an arrow. And then here are some white arrows, and I put some red arrows on top of it, so we can see those are cervical ribs. And we'll talk in a little bit more detail about when they occur here. So cervical ribs, again, cervical ribs, they are supernumerary. They affect less than 1% of the population, so not that common. But interestingly, they affect 1 out of every 10 thoracic outlet syndrome patients. Now, they are bilateral in 50% of patients, but if they're unilateral, they're normally on the right side, okay? And they are usually asymptomatic, but if they're symptomatic, this is oftentimes how they would present. Okay, so there's also muscular anatomic defects. We just talked about the bony ones. There's muscular ones. This would be like an anomalous insertion point of the scalene muscle. Now what's interesting is that there's really one site that's cited almost everywhere as the problem child here, and that's this. There's the anterior, so I don't want to get confusing here. The middle scalene muscle is inserted too anteriorly on the first rib, and that creates too acute of an angle essentially as the brachial plexus and subclavian artery and vein come from essentially from the posterior scalene muscle. As it comes by there, it creates too sharp of an angle there at the middle scalene, okay? And then this is particularly vulnerable to this when the scalene muscle hypertrophies. The brachial plexus, again, goes through the scalene muscles, as we talked about earlier, and so it's vulnerable to that. All right, then of course there's trauma, and trauma can lead to brachial plexus injury itself, which can cause displacement of the brachial plexus, particularly having it slide higher up between the scalene muscles. So remember, the scalene muscles kind of come down in kind of a pyramid shape, and trauma can often lodge them or shove them northward, I guess more cranially into the kind of the crotch of that triangle. And then there's whiplash injuries, which can again displace their normal anatomic location. Then poor posture. There's actually kind of a surprising number of cases that are attributed to this. This is when you have drooping and laxity at the shoulders or a protruding of the head anteriorly. Either way, what you're doing is essentially you're sort of crumping forward. Your poor posture is allowing your head and your shoulders to come down, essentially creating a compression there of your clavicle and your first rib together, and thus altering your anatomy a little bit or enough to cause thoracic outlet syndrome potentially. Repetitive activity, computer typing with poor posture, and then weightlifters, swimmers, and then of course pitchers. That's kind of a high profile one that we've heard about recently. All right, next there's tumors, obesity, and pregnancy. Pregnancy is mainly due to the redistribution of fat. Obesity is due to obviously just a fat itself, and then tumors, it's a mechanical displacement. Okay, so now we sort of understand the where and how the compression occurs. There's those three sites that we talked about, and sort of what can be the major player here, but we still need to classify them a little bit better, and we're going to talk about that here, okay? So as far as there's two ways to classify, and not really two ways, but two complementary ways that you use to describe in the classification system. So first is which system is affected. Now, of significant note, most of these thoracic outlet syndrome will affect both, multiple systems. So there'll be arterial and neurologic, or neurologic and venous compromise. But if they're in isolation, if there's only one system affected, it's almost always going to be neurologic. Okay, and that makes sense because of the vulnerability of the brachial plexus and your sensitivity to brachial plexus insult, whereas your vascular bundles tend to be a little bit more hardy. Okay, and then it kind of makes sense that neuro would be most affected by the reasons we just described, and then venous because of the thinner walls and the easier collapsibility makes it more vulnerable. And then ischemia, due to arterial ischemia, is obviously going to be kind of hard to occur. You're going to have a pretty tight little bind there and a long-term bind in order to cause arterial ischemia that you notice. So that kind of brings us to the severity, which is uncomplicated and complicated. This is not by any means an arbitrary division. Okay, and we'll talk about how it isn't here. Uncomplicated thoracic outlet syndrome is much more common. It's, again, usually a mixed picture of the nerve, artery, and venous subtypes. Almost always misdiagnosed initially. It's real low on, or somewhere distant on most differentials, or not even on the differential. And then it results in this kind of a mild to severe pain, mild to moderate, but it can have severe pain. It's positional, all right? That's an important history fact to sort of obtain from the patient if they figured out how to reposition around it. It's intermittent and oscillating, and there's no atrophy of the hand muscles. So importantly, if the neuro and vasculature of the hand is intermittently patent and intermittently effective, then you're going to retain that the hand musculature. But if it is at all a permanent status, then that will not be the case. And so that brings us to the complicated thoracic outlet syndrome. Okay, so complicated neurogenic is a slowly progressive and unilateral atrophy and weakness. That makes sense. Sensory deficits in C8 through T1 distribution. That makes sense. That's where it will be most affected there. And then there's complicated arterial thoracic outlet syndrome. So this also kind of makes sense. It's non-positional ischemia of the fingers and hands. There can be subclavian artery aneurysms and cerebral embolism as a result of, well, we'll talk about that in a second, but there can be cerebral embolism. You also have Raynaud's and the upper limb claudication, thrombosis, and gangrene, which all makes sense with poor vasculature. Complicated venous thoracic outlet syndrome results in thrombosis of the subclavian and axillary veins. This is if in the appropriate sort of window, and if acute, and if the DVTs look pretty extensive and long, then we call it Paget-von Schroeder syndrome. And Paget-von Schroeder system is exactly that. It's essentially a bunch of subclavian and axillary thromboses that are somewhat extended and incredibly unusual in the absence of something like this. If normally they're in combination, so you'll see like an axillary subclavian combination in the absence of a PICC line and all those other sort of insight factors. All right, regardless of the type, there's usually these non-specific symptoms, including shoulder pain, neck pain, face pain, and occipital headaches. Interestingly, these headaches are reproducible and thus positional. It's kind of an important historical fact, and one that's might lend you towards the right diagnosis, but probably doesn't. That's why it's often a misdiagnosed situation for a long time. There's a couple specific constellations of symptoms, or I guess there's some sub collections of symptoms that come together to make these little syndromes, and these would be these cervical outlet syndrome. This is when the high cervical nerves, so 5, 6, and 7, are impinged up in the crotch of the scalene muscle, like we talked about earlier. Then there's what's called true thoracic outlet syndrome. This is kind of the opposite. This is actually where the brachial plexus, the lower brachial plexus, so C8, 9, and T1 are most affected. This is, again, the cervical outlet syndrome is more likely to be a scalene triangle issue, whereas the true thoracic outlet syndrome is more likely to be a costo-clavicular space issue, okay? And then Paget-Schroeder syndrome we talked about, and this is, again, an uncommon collection of DVTs, particularly when they're subclavian and axillary combined together, raises suspicion here. And kind of the example that, I think a historical example is obviously lots of examples, but one historical example is like a violin or viola player, I think it's a violin player actually, who essentially increased her playing from, or his playing from, 0 to 60, and increased the playing tenfold over the course of a very short period of time. And due in large part to that remarkable increase in exertion, they had he experienced the emergence of this Paget-von Schroeder syndrome. There's a number of clinical tests and maneuvers you can use. We're going to kind of talk through these pretty quickly because most of these really are not that we'll talk about it in a second. But all right, so first is the Roos test. This is where you essentially put your arms by your side and you just kind of reach up in the air. So you're making kind of a 90-degree angle at your elbows. So you put the patient seated, put their head in the neutral position, externally rotate the arms at the shoulders, and then you abduct the arms at 90 degrees. So essentially it's like a big stop sign with both your hands, okay? If that, you make these fists for 3 minutes, you clench, unclench, clench, unclench for 3 minutes. And if you get pain relief, if that elicits pain, and then you get relief after putting your arms down, that's a positive Roos test. And it's fairly specific for thoracic outlet syndrome. Here's an image of it. Hopefully it doesn't quite look like this, but if it does, this is, I guess, would be a positive sign or a positive sign of something concerning. But for the most part, you're just going to have a lot of pain there when they have their hands up like that, making fists over the course of minutes. Next is the Adson maneuver, and this is where the patient, everything says you start this by taking a deep breath, but you rotate and extend the head ipsilaterally, flex the affected side elbow, and abduct that arm. So flex the elbow, abduct the arm backward, and then you wait to see if the patient loses their pulse or has a bruit that's elicited. Now what's interesting here is that historically the bruit was the more important part. Now we actually consider the pulse more important because we just say essentially that's kind of the point. If they have the symptoms down at the hand, that's what we care about. We care less about whether or not a bruit develops. And this again is pretty specific. Now this is the old school picture of this, but what I thought was kind of funny is also in the similar vein is a slightly newer school picture, and it reminds me of a young Tom Vera, so I thought I'd put it there. Anyway, it's kind of a young Tom Vera. All right, now next is Wright's hyperabduction test. This is pretty straightforward. You just essentially put your arm up at 180 degrees, and you see with varying kind of the motion, you do this kind of circular motion of the right arm while they're up. Is there any way you can kind of make their radial pulse diminish? And if so, It's sensitive, but not a very specific test at all. And so here we go. Again, there's lots of videos, as you might imagine, online, especially ones with this girl in this yellow tank top. All right, next is the costoclavicular maneuver, okay? So this is where the patient sits up, kind of drops the shoulders, so protrudes their chest, and just essentially sticks their chest out, okay, for the course of a minute. And what you're looking for, importantly, is not a weakening of the pulse, but you're looking for a weakening of the pulse relative to the other side, because most people, at least according to some of these articles, most people will have a weakening of their pulses in both arms, but you're looking for one that profoundly weakens versus the other, okay? Also, if there is pain or paresthesia, that's a positive test, okay? Very specific, and this is what it looks like. Again, there's a video available if you want. Okay, next there's this, finally, there's this thing called the upper limb tension test, okay? Now this is particularly sensitive for the neuro tissue, and it's important because this is, if you're really trying to clinically bear down on it and which test to get next, if this is positive, you might at least, be more inclined to steer the patient towards EMG, which we'll talk about a little bit later. But anyway, so this is more sensitive for neurotissue irritation. So you essentially turn the head contralaterally, so turn that head away from the side. I'm sure you probably take a deep breath here too. You abduct that arm, the entire arm, and then you extend the elbow. And if you get pain, that's a positive test. And it's actually remarkably sensitive, 95%, and not specific. So there's two ways to do it. One is the way that sort of is described there classically, which is where you sit up and do it. But there's also this way where you essentially lay on your back and the examiner kind of does it for you. And it seems to be that for the most part in all the modern literature and such, that's kind of the way that everyone's doing it. All right. Next are the radiologic studies. So no one really, I assume not many people are ordering plain C-spine films for this initially. But if you do, you'd see cervical ribs and elongated C7 transverse processes that might be the kind of like pseudo cervical ribs that might be at play here, or degenerative spine, or of course bone tumors or lytic lesions. You can the best first test for most of this, especially if they're having obviously vascular symptoms, is the upper extremity duplex. This is used mainly for venous disease, but could obviously be used for arterial disease as well. You get an MR or CTA. This is for best actually for if you have for monitoring, I guess, aneurysms and resolution of thromboses and things like that. It's not usually done as a first-line test. Ultrasound, if you look on the exam or whatever, ultrasound is the best first test if they're having vascular compromised symptoms. If they're not, then nerve conduction studies make sense, so EMG. Sorry about the studies there, but STUIs. All right, so ulnar nerve sensory amplitude. So there's two kind of things you're looking for is at the ulnar nerve, the sensory and the motor amplitude, okay? So I'm sorry, the sensory amplitude and the motor, the strength of the motor signal, so the motor potentials, how many times it can reset. So what you're looking for in the sensory side of things is you want to know that amplitude is halved, so the intensity of the signal is halved in half. Whereas in the motor, you want to know that there's half of the essentially half the potential, so half of the frequency of potentials. All right, so what are the therapeutic options? So just like everything, we start with non-operative therapy. So it's postural improvement, breathing exercises, avoiding weightlifting, avoiding repetitive upper extremity mechanical motion, and then physiotherapy. And of course, analgesia and muscle relaxants. Interestingly, here is this final option, which is antidepressants. Antidepressants are, there's a lot of recent literature suggesting antidepressants seem to help a lot here, but certainly when used in conjunction with the other things, probably giving a patient the best shot of non-operative management. And we'll talk in just a minute. I mean, the non-operative management actually works pretty well. There's also Botox. You inject this under ultrasound and EMG guidance just to kind of make sure that, number one, you're in the right area, and number two, you're not too much in the right area that that you're doing damage. 2 weeks until onset, so it's a slow onset, but interestingly, once it's there, you have a pretty long effect. I think I have it here as 3 months. Yep, so 3 months the duration of efficacy. So it may take a while to build up, but once it gets there, it'll be effective. You go to the surgery, you go to the OR if the symptoms are refractory, pretty common sense stuff. If the symptoms are refractory to non-operative management, or there's a significant vascular compromise, or there's advanced neurologic symptoms, or the nerve conduction velocity is less than 60 meters a second, which is very, very, very slow, and so that's essentially suggestive of, I mean, the patient would already be in for some other issues at that point. So that would indicate it's a pretty significant nerve impingement. So there's, as far as the vascular things, the vascular flow studies are pretty straightforward. If you obviously lose flow in certain area, in certain positions and whatnot. So I wanted to talk more here about just if there's thrombosis. So both venous and arterial thrombosis are amenable to operative intervention, but generally you do catheter-directed thrombolysis, the thrombolysis first, okay? If it's severe, however, just go for the embolectomy. And then you start anticoagulation on postoperative day 3, and you do it for a 6-month duration of anticoagulation. Now, there's been some modern refinements. That's kind of I think that's the Stavistons policy there. But if they're still thrombosed, then you do that 6 months of anticoagulation. So the new evidence is saying, hey, give them 2 weeks, and if it doesn't come back within those 2 weeks, then you're probably good to stay off anticoagulation as long as they're contributing, or as long as they're participating in all the activities. If, however, they thrombose up again despite their participation in those activities, then it's time to kind of move towards that 6 months of anticoagulation while continuing all those other interventions. So majority of patients, up to 60% that have the neuro symptoms will recuperate with conservative measures. So the neurologic symptoms tend to recover pretty well, tend to recover pretty well, especially those patients in that kind of that small percentile that have only neuro symptoms. If you have only neuro symptoms, you tend to respond very well to non-interventions, okay? So this is kind of how we proceed along there. We do ergonomic modifications, and we talked about posture and stuff like that, physical therapy, NSAIDs, muscle relaxants, and antidepressants. Again, antidepressants is kind of hot off the presses here. Lidocaine scaling block is an option in order to sort of resolve undo the hypertrophy that's occurred if possible. And then there's a pre-op evaluation for FRRS. And so what is FRRS? FRRS is a first rib resection and anterior scalenectomy, okay? And of course, you can look the procedure up online or in the books or whatever you want to do. But at the end of the day, I'll just give you the key points. I think, frankly, this will get you a long way. There's 2 approaches, a transaxillary or a supraclavicular incision. You have to completely resect the first rib, okay? So that's a key point. There's a lot of half, I guess if you can remember, half the first rib is half-assing or something like that, because you're supposed to take the whole first rib, okay? And then you completely resect these cervical ribs, whether or not they seem to be in play or not, okay? And it's because they will move with the resection of the first rib. They'll come down, and the second rib will actually come up just slightly, but the first rib will come down significantly, at least according to these articles and such. So that's why you resect it if it's there, okay? You resect the entire anterior and the middle scalene muscles, okay? And then remember that a lot of these, if there's a vascular impingement or chronic vascular insult, especially an arterial insult, you may get an aneurysm, okay? And if the aneurysm is present, now is the time to do that arterial reconstruction, okay? Don't come back later, just do it right now. All right, and so that's a wrap. Most of the stuff's in the Stavistons, but you can see the other stuff I looked at, and of course, let me know if you have any questions, and we'll move on to further exciting lectures to come here.